Hi there, welcome to the Frequency Specific Microcurrent November 2016 webinar. This webinar is aimed at practitioners and patients who are looking for information about frequency specific microcurrent. This is Dr. Carolyn McMakin, and I'll be leading you through this exploration of frequency specific microcurrent, our history, and the data that supports what we're doing with it. It's simply magic, or as close to magic as you can do in modern medicine. The frequency-specific microcurrent has become pretty widely used because it provides a new tool for old problems that are really difficult for medicine to manage, things like nerve pain and inflammation. The background for the specific frequencies is that the frequencies were developed in the early 1900s, starting probably about 1908 through 1934. They were used by thousands of physicians in the US and England and Australia, I think, but in the US. And in 1917, the Flexner Report began to be enforced, and the Flexner Report wanted to standardize medicine. Flexner Report said that drugs and surgery was the way that medicine was going to go. Those are the tools that were allowed, and anybody that used homeopathy, herbs, nutrition, or electromagnetic therapies would lose their license to practice, which at that time was granted by the AMA. So in 1934, that prohibition became very definite and serious. And the AMA said that any physician who used electromagnetic therapies would lose their license to practice, which at that point was granted by the AMA. So the machines that were in offices all over the country went into the back room and got covered up by a sheet. That's 1934. 1946, Harry Van Gelder was an osteopath and naturopath. He was Australian. He's actually Dutch, but he was born in Australia. After the war, he went to England and went to Osteopathic Naturopathic College. And he bought a practice in Vancouver, BC in 1946 that came with a machine and a list of frequencies that was created in 1922. So he walked into this practice that he bought and went into the back room, and there was this machine with a sheet over it. Took the sheet off. Under the machine, there was a list of frequencies. George Douglas went and worked with Harry Van Gelder in 1983 and brought the list of frequencies back from that machine, written on pieces of binder paper, and stuck them in a drawer in 1983. 1992, George Douglas purchased a precision microcurrent. It's a 2-channel, 2-digit specific machine, microcurrent device. And he bought that because he liked microcurrent. Well, in 1995, he ran across the frequencies, found them in the drawer. And he looked at the machine and thought, well, this machine has 2 channels, just like Harry's old machine. I wonder if the frequencies will work on a microcurrent machine. And we tried them starting in 1994, 95, 96, treating mostly myofascial pain and various kinds of illnesses and injuries. And the frequencies appeared to do exactly what they were alleged to do, especially in the area of myofascial pain. So I started teaching the frequencies in 1997, mostly to find out whether or not the effects that we were achieving in the clinic were reproducible. By June of 1997, we knew that the effects were reproducible. Anybody could do it. So I kept teaching it because, honestly, it would have been immoral not to. The people that were able to help with the frequency-specific microcurrent are usually patients who have failed with many other kinds of therapies. To be honest, I have no idea how the frequencies were derived, and I don't actually care. I'm a clinician. My only interest really is whether or not the frequencies work and do what they are alleged to do. The mechanism of action is uncertain. We're not really clear about that, although we have a fairly reasonable model that is now testable. So that's exciting as we go forward for the next 10 to 20 years. We've been doing frequency-specific microcurrent for 20 years now this January. I can tell you that the 1920s equipment was not microcurrent. It was plug in the wall, DC, or maybe a huge battery current, but it wasn't microcurrent. That much we know. So the old problems in medicine that are difficult are healing injuries, post-operative repair, and wound healing. Repair limitations, like what limits the ability to heal injuries? ATP production, you need energy to heal injuries. You need to build blood supply, you need to build collagen, and to be functional, wound healing needs to have elastin. So the question you need to ask is, what would happen to healing if you could increase ATP production by 500%? And that is exactly what micro-amperage current has been shown to do in 3 different studies. Nok Cheng did the first study in 1982 in rat skin. So he found that current between 10 and 500 microamps increased ATP production in rat skin by 500%. It increased protein synthesis by 70% and amino acid transport, which would be used to build protein. It increased that by 40%. Current up to 500 microamps caused these increases. Between 500 and 1,000 microamps, ATP production leveled off, and above 1,000 microamps, ATP production actually declined. Seegers in 2001 and 2002 repeated this study and added additional parameters that she tested, and found that in addition to increasing ATP production by 500%, microamperage current up to 500 microamps increased cyclic AMP in human lymphocytes in vivo. So these were live cells. And she makes a statement that it activates signal transduction. Not entirely sure what that means, but it verified Nok Cheng's findings. So microcurrent, the devices, are approved in the category of TENS devices. Millionths of an amp. The current is millionths of an amp. TENS is thousandths of an amp. So the microcurrent devices out there are not TENS devices, but the FDA has categorized them as TENS because they have batteries. So there is a non-prescription use of microcurrent for aesthetics or skin, youth skin treatments. TENS devices are prescription. If you're using them in a medical setting, they're billed as TENS devices. Microcurrent devices vary widely. They've been out since the 70s. There are single channel, there are double channel, they're all direct current, although there are some that plug in the wall and step down the wall current to DC current. They're all DC, direct current, battery operated, pulse DC, or the wall current has to be stepped down. There are different waveforms available that people make all sorts of claims about. Square wave, sine wave, tsunami wave, ramped square wave. What we found clinically was the square wave forms worked the best. We tried sine wave devices and didn't work. So we've ended up using devices that provide a ramped square wave. There are single channel, double channel devices. There are combined units that just run presets and single frequency. In general, the frequency is not important. There's either a limited number of frequencies or a sweep of frequencies. The AccuScope provided a sweep from 0 to 1,000 and back down on one single channel. So lots of devices. But the effects of the current are by itself, without what we've found to be true about adding the frequencies. This was done in rabbits, and it's just 0.3 of a hertz, I think 0.3 of a hertz and 0.9 hertz. It was run for an hour a day, 5 days a week for 4 weeks, so 20 days of microcurrent. The bunnies were, this was done in rabbits at University of Washington. Rabbits were biopsied and then treated for 20 days and then biopsied again. And what they found was that vascularity, the blood supply to the tissue, increased by 39%. Collagen, if you can see the little stripes on that slide, collagen increased by 14%, but more importantly, for functional wound healing and injury repair, elastin increased by 48%. This means that the connective tissue that's laid down in wound healing when you use microcurrent is less stiff and more easily remodeled by the body to be functional. So that's important in wound healing. So you have to ask yourself, what would happen to injury and wound healing outcomes if you could increase ATP, vascularity, collagen, and elastin? That's just the effect of the current. That doesn't count what we found as the effect of the frequency. So the current alone provides these benefits. In delayed onset muscle soreness, it's a condition that happens after you do eccentric muscle contraction. And Denise Curtis did this study in Ireland. She compared FSM to a paper done by Allen in 1999. Allen's paper was a negative trial. That is, it showed that single channel microcurrent using either 0.3 of a hertz or 30 hertz for 20 minutes had no effect, was no different than placebo on delayed onset muscle soreness. They were both run for 20 minutes immediately after exercise. And so the studies were as close as you can be to replicating a paper, 10, 11 years after the first one. In Denise Curtis's study, the frequencies were used are 18 hertz on A and 62 hertz on B, which in our world means to stop the little bit of bleeding that's going to happen when muscle tissue tears. 124 is torn and broken, inflammation. So it's a fairly simple frequency combination. The tissues that were treated were the muscle belly, the fascia, and the tendon. So those are the frequencies that were used. And these are the results. The treated legs, so it was in the same patient, so we didn't have any patient variability. Both legs were exercised. The treated leg, at 24 hours, the pain level was a 1.3. The sham leg, or the placebo leg, was 5.2. The patient had no way to know which machine was on and which machine was off because you can't feel the current. It's physiologic. It's the same kind of current that your body produces on its own. At 48 hours, the patients could really tell which was the sham leg and which was the treated leg. So pain level at 48 hours was 1.2, sham leg was 7.0. 72 hours, the treated leg was less than a 1, and the sham leg was still a 4. So the p-value, which is a statistical measure of effectiveness, is 0.0005, which means there's less than 1 chance in 100,000 that this could be a coincidence. And it was in all of the patients tested. And the thing about delayed onset muscle soreness is there is no other effective prevention or treatment. Nothing else works. So when people, athletes especially, get sore after exercise, there's nothing they can do to relieve the soreness. And if you can look at the pain values, pain of a 7 out of 10 is pretty intense and will prevent the patient or the athlete from exercising that area again because the muscles are so sore. So this would be why FSM is in the training rooms of so many NFL teams, and there are so many personal units, frequency specific pre-programmed personal units with over 200 professional, Olympic, and elite athletes. We're really proud of our NFL connections, and really enjoy being able to help these athletes perform at the peak level. Post-op outcomes. This study was done by an OBGYN. The control patients, so we had a placebo group. No, they weren't a placebo group. This is an untreated group, treated with standard medical care after C-section surgeries. They were in the hospital for 3 1/3 days. The FSM treated group got out of the hospital about 1/3 of a day, half a day sooner than the untreated group. Postoperative pain at rest. It's a difference between with medication. Difference between a 1.8 and a pain level of a 0.5. With activity, so when they want the patient to get up and move around, it's a difference between a pain level of a 5 and a pain level of a 3. This is a huge advancement in managing postoperative pain and postoperative injuries. Diabetic wounds. The frequencies for the diabetic wound treatment are the frequencies to reduce inflammation in the blood vessels and in the tissue. So this was diabetic ulcer that was healed in 6 treatments over 3 weeks. This original case report was done in 2002 by Norrie Collier. And if you look at his toe, this was, there's necrosis, the tissue's dead, almost down to the bone, and that toe was set to be amputated about, I think, 2 weeks after this picture was taken. 9 days later, there's healthy tissue, the necrosis is gone, the wound is granulating and filling in, and 11 days after that, it's filled in. There's a little bit of necrosis left over on the side, but the wound is almost closed. So the combination of the current and the frequencies to reduce inflammation in the blood supply and the connective tissue are just profound in wound healing. So old problems in medicine: inflammation, degenerative diseases, and immune system activation. Inflammation is behind virtually every degenerative disease: asthma, ulcerative colitis, neurodegenerative diseases such as dementia and Parkinson's, and liver disease and lung diseases. Basically, inflammation is essential to protect us from infection and cancer, but when it gets out of control, it causes serious difficulties in illness and in health. So the problem with anti-inflammatory drugs is they take too long to work. There are too many side effects. Non-steroidal anti-inflammatories cause kidney damage to the intestines and the stomach because they block all of the prostaglandins, not just the ones that cause inflammation. They block the prostaglandins that rebuild the lining of the gut wall and the prostaglandins that rebuild the lining of the blood vessels. So the non-steroidal anti-inflammatories were a great advancement in treatment, but they have these problems that have caused certain of these drugs to be taken off the market. And the medications that change cytokines are inflammatory peptides that mediate inflammation down a different pathway than the prostaglandins. But in general, in medicine, they're hard to change. And when they change slowly if they change at all. So the new biological drugs that lower cytokines take 2 to 3 months to work. And one of the challenges that we have with those medications is that they take the cytokines below normal levels, so the patients who are taking them end up having difficulties with infections and cancer. So can the frequencies help with this problem? And the answer is yes. Functional medicine is the modern approach for the old problems in medicine. So functional medicine, and for those of you that are out there, they're functional medicine practitioners. Functional medicine is a modern approach for the old problems in medicine. It approaches why the system gets dysfunctional. So from a functional medicine approach, if a patient has asthma, you look at why the immune system is hyperactive. And when you go to treat an asthmatic in a functional medicine paradigm, you treat the gut because 85% of the immune system is clustered around the gut. So you want to quiet down the allergy response in the gut that sets off the immune system that causes the asthma. Functional medicine is my favorite approach to medicine and has been for 20 years now, but it has a challenge. It takes too long because in order to get the system to turn itself around, it takes about 6 to 14 months. Most of the functional medicine data shows magnificent responses, but they take 14 to 16 to 18 months to produce. And complying with those kinds of prescriptions for diet, supplements, and nutrition takes a long time, and it costs a lot of money. So how can the frequencies help reduce inflammation in either a traditional medicine or functional medicine paradigm? We have data that shows that very specific frequencies reduce lipoxygenase-mediated inflammation by 62% in 4 minutes, and COX mediated inflammation by 30% in 4 minutes. Both LOX and COX are prostaglandins that mediate inflammation, and these reductions in inflammation are unheard of in medical therapy. The COX-mediated inflammation reduction is equivalent to injectable Toradol, which is what they give patients directly after surgery. And we do it in 4 minutes with virtually no side effects that have been observed in 20 years of use. So this is the study that was done in Australia by Vivian Reeve and Wayne Riley. They painted arachidonic acid on the mouse's ears, and that arachidonic acid causes swelling. Then Wayne grabbed the mouse. I don't know if you can see it, but he's got the mouse by the scruff of the neck and the tail. And he's treating him with 40 hertz on channel A and 116 hertz on channel B. And when they did the first 10 mice, they had a 70% reduction in swelling. And Vivian called a halt to the experiment because in 20 years of doing anti-inflammatory research in the same mouse model, she'd never seen a prescription or non-prescription drug that reduced inflammation by more than 45%. So she figured it had to be a placebo response. So she shut down the experiment, created a new group of mice, 20 of them this time, turned the machine away from Wayne so he couldn't see, put in a placebo frequency, and she moved the people that were measuring the mice, the people that were painting the mice, and then the guy that was treating the mice, all into separate rooms, closed the doors, and put in a placebo frequency. And with all that care taken to make the results credible and placebo-proof, there was still a 62% reduction in LOX-mediated, lipoxygenase-mediated inflammation, and still a 30% reduction in COX-mediated inflammation. It's interesting that all the animals responded, so there's no animal that didn't respond. And it was a 4-minute time-dependent response. So half the effect was present at 2 minutes, and the full effect was present at 4 minutes. Then there was a group of mice that they sunburned. So if you sunburn somebody, these are little hairless mice with little hairless ears. If you sunburn somebody, it gets red and swollen and inflamed. So this is the group that had no treatment. So they had a placebo control. And this is the amount of swelling at 21, 23, 25, and 27 hours. Then they had a group that was treated with 40 and 116 immediately after the sunburn. And they had some reduction in swelling, but it was not statistically significant. Then there was a group that was treated at 2 hours, and they all had a statistically significant reduction in swelling to the degree of 0.01 at the 27-hour mark. So that was pretty exciting news. But here's the other piece of it that was quite Surprising. The fact of the matter is that sunburn suppresses the immune response. That's one of the reasons that sun therapy is used in psoriasis, is it quiets down the immune system. So part of this experiment was to paint a contact sensitizing agent on the hind leg of the mouse at the time of the UV exposure. 2 weeks later, the same agent was painted on the ear. The normal response is 30 units of swelling. It's kind of a fuzzy slide, but 30 units of swelling. And then you can see that the group that was sunburned had their immune response suppressed by 63%. So immune suppression is one of the results of sunburn. The group that was treated at 2 hours, the one that had the best reduction in swelling, had their immune suppression reduced from 63 to 57%, which was kind of nice, right? 63 to 57%. The group that was treated immediately, the one that had minimal to no reduction in swelling, had their immune suppression reduced by half when it was measured 2 weeks after the frequency was applied. That's pretty extraordinary, actually. It means that a single 4-minute application of one and only one frequency combination reduced immune system suppression by half 2 weeks after it was applied. It suggests that the effect of the frequencies is permanent and creates changes in intracellular function that are profound. So I think this slide is in the wrong place. But it's related to the reduction in inflammation. The FSM outcomes in peripheral neuropathy are extraordinary. So this patient had 8 out of 10 sensory areas in the foot completely numb. And after 8 treatments in 4 weeks, the feet were no longer numb and no longer painful. So this is the same guy who had the wounds healed on his foot. So the reductions in lipoxygenase and cyclooxygenase inflammation are profound because LOX and COX inflammation are associated with all degenerative diseases: asthma, COPD or emphysema, irritable bowel, Crohn's, acute and chronic pancreatitis, ulcerative colitis, liver disease, rheumatoid arthritis, and degenerative arthritis. If you can reduce lipoxygenase mediated inflammation by 62% and COX inflammation by 30%, you can affect changes in all of these conditions. So what would happen if you could reduce all inflammatory cytokines in 90 minutes, as long as they all stopped in the normal range? So we had a study that we did on 54 fibromyalgia patients with a history of trauma. They were an average of 9 years chronic. They had pretty much tried everything and failed. Blood sample data, we treated this group and we had the opportunity to have blood samples tested at NIH, thanks to the grace of Terry Phillips, who is a biochemist. So he measures teensy little dosages of peptides in the blood. So the blood sample data was done on a subset of 6 patients that did not differ in either age, pain, or chronicity. And there was a control patient that had myofascial pain from trigger points. So when you think about fibromyalgia, and specifically fibromyalgia from spine trauma, there are 6 million fibromyalgia patients in the US. 28% of them have fibromyalgia associated with spine trauma or some sort of trauma. That's 2 million patients. And I had been treating these people for 3 years, before we stumbled across a frequency combination that would take their pain down. 40 hertz on channel A is the frequency from this list I got from the osteopath for reducing inflammation. And 10 hertz on channel B is the frequency on the list for addressing the spinal cord as a tissue. So the way FSM works is there's a frequency on channel A for a condition, and there's a frequency on channel B from the list that is thought to address a specific tissue. So clinically, these two combinations, and there were dozens that we tried and used over the years before we found this combination that would actually work. And it took their pain down from an average of a 7.4 to a 1.3 in 90 minutes. Now, recovering from fibromyalgia is a different thing than getting your pain down. They would have FSM in the office to keep their pain down about once a week. Many of them had a home unit that they used at home to keep their pain down. Most of them were sent to physical therapy for spinal stabilization and reconditioning. Most of them took supplements to treat the other conditions that they had, the irritable bowel, the adrenal fatigue, and in some cases, interstitial cystitis. And in that subset of 6 patients who had their blood samples measured, the initial patient is this graph one. She's the first one. She had her interleukin-1 is a peptide that's associated with nervous system inflammation in particular. And her interleukin-1 went from 392 down to 21. That is unheard of. In the medical realm, cytokines change slowly, if they change at all. And slowly means over months. So this level of reduction in inflammatory cytokines has never been seen or done in any medical therapy to date. This paper is the only one. So we had 5 patients. One of them, she didn't respond, so her pain level didn't come down very much, but her cytokines still came down by half, which is pretty satisfactory. The other 5 had their cytokines come down very nicely. Second visit, we had 2 patients that we were able to follow. There was only 1 patient where we got measurements on all 3 visits. TNF-alpha, which is a inflammatory cytokine, went down from 299 down to 20. And in the collective group, it went from 305 to 78. This p-value has 0.002. It does mean that there's virtually no chance that this was coincidence or placebo effect. Interleukin-6 went from 204 down to 15. 239 down to 76. The p-value is 0.008. Look at there's no scatter in these 4 measurements. They're all very close. So it's not like they were all over the map or that it was a small response. It's a fairly huge response. Substance P is produced in the spinal cord. So if substance P goes down, I am told by Dr. David Perlmutter, if substance P goes down, it means that you are indeed affecting and changing the function of the spinal cord, and that's exactly what we did. It went down by a factor of 10 times, which is likewise unheard of in medicine and any medical therapy. If you look at the grouping for these 4 patients, it is very tight, and substance P went down dramatically and all like by factors of 10 times in these patients. The patient whose pain level did not go down still had her substance P reduced by a factor of 50%. So with her, what she found was that during the treatment, she didn't have much response, but the next day and for the next 2 weeks, her leg pain was gone for the first time in 2 years. Endorphins went up. These patients, about the 20-minute mark, well, 30 minutes in here. So the treatment started at 10 minutes to 11. And by 11:30, so 45 minutes into the treatment, endorphins have gone up by a factor of 4 times and 2 times, 20, 40, 60, 80. Anyway, by 11:30, the patients are pretty much so stoned that they don't feel like talking. The blink rate slows down, the respiration rate slows down, they get pretty floaty. And one patient asked me, "Is this legal?" And so she rather enjoyed it. Their endorphins continue to go up until they would really rather not open their eyes. P-value has 0.003, which is huge. And the endorphins come back down fairly quickly. So by the time they're finished being treated and they've gone to the restroom and changed their clothes and paid their bill, they're just fine to drive and function outside the clinic. Cortisol was shown to go up, which may have been useful in reducing the inflammation, but it's not a stress response because the cortisol followed the endorphins and lagged behind the endorphin measurements. We're trying to find out if it was a stress response, but unpublished data that was collected on the same patient shows that neuropeptide Y drops, which means, and neuropeptide Y follows the sympathetic nervous system. So it's not a stress response. It appears to be a side effect of the endorphins going up. So when you create beta endorphin, you split pro-opiomelanocortin into ACTH and beta-lopotropin, and the ACTH is going to drive cortisol up. So this appears to be a side effect side effect of the endorphin response. Pain went from a 7.3 to 1.3, and that p-value is 0.001. If you do the math, for those of you that are statisticians out in the audience, if you do the math, that p-value actually has 6 zeros, not 3. But the statistician is British, and he said that anything more than 3 zeros is showing off. So we only published the 3 zeros, which was kind of fun. So all patients experience pain relief, and of the fibromyalgia patients, this group is the most difficult and have the highest pain levels. 58%, or 31 out of the 53, experienced resolution of the fibromyalgia within 4 months. That means it went away. Condition went away. Their tender point sensitivity went down. The central sensitization was assumed to go down because the tender point sensitivity went down. Their body pain went down. Their sleep quality improved. Their use of medication improved. 1 patient relapsed. 13 out of the 53 discontinued treatment for reasons not related to treatment side effects. It's actually pretty disorienting if you've been in pain for an average of 9 years and in 90 minutes your pain is gone. It creates an existential crisis that's sort of unparalleled in medicine, actually. Everything else we do medically to treat patients, the patients have time to get used to the fact that they're now out of pain or their condition is now changed. This is 90 minutes. Now the pain will return, and then you relieve it again, and it'll come back at a lower level, and you relieve it again, and it never doesn't work. If it works the first time, it will always work. And so around 60% of these patients can recover from fibromyalgia. When you think of the amount of suffering and disability that fibromyalgia of this type, of any type actually, fibromyalgia causes, that kind of recovery rate has extraordinary implications for the relief of human suffering. So this is a patient who was 18 years chronic. On December 8th, she had 14 of 18 tender points tender to less than 4 pounds per square inch pressure. 1 month later, she had 11 of 18 tender points, and 1 month after that, so after 2 months, she no longer had fibromyalgia. So the diagnosis of fibromyalgia used to depend on 11 of 18 tender points tender to less than 4 pounds per square inch pressure. And so in 2 months, she no longer met the diagnostic criteria for fibromyalgia. Her cervical range of motion improved by 40%. She sometimes took a pain pill once or twice a week. She sometimes took muscle relaxants to sleep or to help with muscle tightness. She was sleeping well with no medication. Digestion improved. Irritable bowel resolved. Her acne improved. Her asthma improved. And at 6-year follow-up, I called her in Colorado, and she was still recovered. So nerve pain, muscle pain, and scar tissue. The problems that we have in medicine and physical medicine especially is the treatment takes too long, costs too much, and doesn't work very well. So with FSM, neuropathic pain is really the easiest thing we treat. I started treating it in 1998, 99, and finally did a collected case report in 2010. This N of 20 represents, I don't know, a very small number of the hundreds of patients we treated over the years, but it was the only group I could put together to meet the diagnostic criteria and create a publishable paper. So they're typical. Nerve pain is easy to treat. It's 40 hertz on channel A and 396 hertz on channel B. Pain was reduced in the first treatment from a 6.8 to a 1.8. P-value is 0.001. Second treatment went from 4.8 to less than a 1. So there's some residual benefit even when the pain comes back. It's lower than it was before. 65%, so 13 out of the 20, fully recovered in about 5 treatments. There were no adverse reactions aside from getting a little bit stoned. The nerve traction injuries are the easiest to treat. Disc injuries are the things that take a while because you have to repair the disc in addition to treating the nerve pain. 25% terminated care prior to recovery, either for cost or travel time or that existential crisis that we just talked about. Cervical myofascial pain was the first paper I published. 50 cases were published in 1998. 5 years average chronicity, range of up to 28 years. 88% had failed with other treatments, so the patients formed their own control group. If they were going to have a placebo response, it's assumed that they would have had it with one of the other 6 things that they had tried. 11 treatments in 8 weeks to take the starting pain score from a 6.8 down to a 1.5. And it took 11 visits in 8 weeks, honestly, because in 1997 and 1998, I didn't know what I was doing. So much of myofascial pain is especially in the cervical spine, is secondary to disc injuries, facet injuries, and ligamentous laxity. Once we figured out that those were the primary causes of myofascial pain in the cervical spine, then our outcomes became much quicker and more like what we see in lumbar myofascial pain. These are 23 cases that were published in JBMT in 2004. 8 years average chronicity. Patients served as their own control because 87% had failed with other treatments, and it is presumed that if they were going to have a placebo response, they would have had it with one of the other 6 things they tried. 6 visits and 6 weeks, and this is pretty typical in true myofascial pain. Starting visual analog scale is a 6.8, the ending is 1.6. So getting muscle pain down is pretty straightforward. We did a research project at a burn center in Springfield, Missouri, and 8 patients with chronic burn scarring. Every patient had statistically significant increases in range of motion in 3 one-hour treatments. They were measured on Monday before treatment by physical therapists and occupational therapists in the burn unit. They were measured on Friday, and then they were measured every week for 4 weeks, and then once a month for another 3 months. And every patient had statistically significant permanent increases in range of motion after 3 one-hour treatments. What that meant was that a 14-year-old girl had the scars on her face relaxed enough that she could smile. That a 47-year-old man could make a fist and hold a coffee cup. That a young man who had the skin on his legs burn from just below his hips to his feet could bend his knees, bend his ankles, get into a brace, and get out of a wheelchair for the first time in 3 years. So dissolving scar tissue is fairly straightforward. We did research in the abdominal adhesions at Baylor Medical School with David Weissman. He would induce an abdominal adhesion he induced abdominal adhesions surgically in a rat the week before I got there. And the next week we had permission to open up, anesthetize and open up 3 of the rats. And I used the microcurrent across the abdomen and tried about 6 different frequency combinations. And we got to one particular frequency combination, 13 hertz on channel A, 77 hertz on channel B. This white, hard, gristle-like area of scar tissue literally became clear and liquefied. It just turned to snot. And running frequencies in different order, that one frequency is the one that liquefied the adhesions. So when you use FSM and manual therapy, this is Kim Pittis. She teaches our sports medicine specialty class. And she is working on, I think he's a swimmer, but he has adhesions in his lumbar spine between what appears to be his ureter and the quadratus lumborum. And so those of you that are manual therapists, you combine the frequencies. So this towel that's up under his armpit, there's another towel at his under his bum here, under his backside, and the frequencies run through the tissue. And when you're reducing scar tissue, the frequencies vibrate the connections loose, and then you stretch them and the scar tissue goes away. So the frequencies are the new tool that allow you to do what is impossible in medicine otherwise. The frequencies were developed in the 1900s. I think I already told you the story. The list was resurrected in 95. And because of the way the AMA and the FDA have handled things, we have no idea how the frequencies were derived. And modern biophysics is just now creating models for the mechanism of action that include resonance with cell membrane receptors and changes in intracellular function. There's one frequency, the only thing it's good for is shingles. This was a case of shingles in the ophthalmic branch of 5 in an 85-year-old man. 4 hours of treatment. He was pain-free in 1 hour. There was no return of pain, and the lesions were gone in 48 hours. That's impossible. It simply can't be done, especially not in an 85-year-old man. There's only one frequency combination that reduced inflammation, 40 hertz on A and 116 hertz on B, and they tried 1/10 of a hertz, just non-specific old-fashioned single-channel microcurrent. That did nothing. Other frequencies that we use even within our system, that did nothing to reduce swelling. And the frequency to reduce inflammation in the skin, 355 hertz, created no reduction in swelling. So here's the model for how it is these frequencies work. The human body is basically a quantum biological system. As a whole structure, you obey the laws of Newtonian physics. But when you get down to a molecular level, you become a quantum system. So living tissue, you, me, is biochemicals. Biochemicals are made up of molecules. Molecules are made up of atoms. Atoms are made up of subatomic particles. All of these molecules, atoms, and subatomic particles, all of your tissue is held together by electromagnetic bonds in particular configurations that make them into cell membrane receptors or different kinds of tissue. In physics and engineering, every bond has a resonant frequency. That is a frequency at which it responds to vibration. Your body is in fact an electromagnetic system that looks solid, but the cells function as if they are a semiconductor network that conveys current. We know from Becker that you are polarized positive at the top, negative at bottom. So current, charge, and vibrational information. There are some processes in the body that happen faster than it's possible for chemicals to respond. So it has to be happening from an electromagnetic signaling perspective. Membrane protein receptors determine cellular function, and these receptors reconfigure in response to stimuli. The receptor changes alter cell signaling and cell function. So when a little piece of a bacteria or a frequency, when a little piece of bacteria lands on this receptor, it causes the cell to create pro-inflammatory cytokines. When the frequency changes this receptor, it causes the pro-inflammatory cytokines to go away. And so drugs, nutrients act like keys in a lock to change this membrane receptor function. So you think of drugs and nutrients as acting like a physical key in a lock to change this receptor. And that receptor change creates a change in cellular function and genetic expression. The frequencies act like your key fob that opens the same lock with an electromagnetic signal. It changes, it appears to, let's put that, we don't have proof of this yet, but it's a reasonable model. It appears to change membrane protein configuration and cell function electromagnetically. It acts as if it dissolves scar tissue cross-links, and then all you have to do is move them to dissolve them. It acts as if it disassembles the virus capsid in shingles, and it acts as if it changes cell signaling in inflammatory conditions because it turns off cytokines, but they stop in the normal range. It turns off LOX and COX prostaglandin production, but they stop in the normal range. So if you want to learn how to use FSM or learn more about FSM, look for Frequency Specific Microcurrent in Pain Management. It's published by Elsevier, and it's available on Amazon or at our website, frequencyspecific.com. I teach this technique, Frequency Specific Microcurrent, as a 3-day seminar. The frequencies are a new tool that solve very difficult old problems for your practice and your patients. Go to our website to download the published papers, www.frequencyspecific.com. And I have to warn you, frequency-specific microcurrent will change your life, your practice, and your outcomes forever. If you have questions, click on the question mark on the left side of your screen, and we have about 10 minutes, and we'll get to those. I'll answer those as they come in. So, oh, and we'd like to, here's one from Cancun. Share your suggestions for implementing FSM treatments into practice. I have a back room. Can you leave a patient on FSM while you continue to treat other patients? Are there greater clinical benefit with fewer longer sessions or frequent shorter sessions? And what would you suggest we start with? Oh, it's Alma again. Hi, Alma. You can leave the patient to be treated. There are automated units that run protocols, let's say, for irritable bowel, kidney stones, asthma, concussion, liver inflammation. Those are all automated. You don't have to be there for that part. The physical medicine protocols are actually more efficient if you're there doing them manually. And so the precision care is good for that. We have a new unit coming out next March, and that unit will have a manual and automated option on the same unit, so that'll be fun. But for right now, you can use the custom care as a manual unit or the precision care as a manual unit. And then, I don't know, frequent shorter sessions, yes, except for fibromyalgia, it's a 60-minute thing. So that's unattended. You hook them up neck and feet, run 40 hertz on channel A, 10 hertz on channel B, punch a button, leave the room. You don't have to be there. It works whether you're there or not. So the question, I am afraid, the answer to that question, I am afraid, is it depends. You got to take the course or read the book to get an idea. FSM is fairly straightforward once you learn it, but it's very diagnosis or assessment. It's very individually customized for the patient and the practitioner. If you have a 20-minute slot where you can be in the room with the patient, then your treatment times are going to be 20 minutes, and you'll figure out how to make it work and do what you want to do in that 20 minutes. Fibromyalgia patients, they take an hour. So you don't have to be there, but they take up space, not your time. I would suggest you start with the course on DVD or read the textbook and just see what you think after learning that material. We have any other questions? We have, we're offering $200 off our core training seminar. That's either in person or on DVD. If you click on the shopping cart on the left of your screen, that will take you to our list of course seminars that are currently scheduled. When you check out, use the coupon code CORE200. CORE200. So it's a $200 discount off of the core seminar. The code is all lowercase, all one word, and this coupon is going to be valid through the end of 2016. The course is great fun. even when you take it on DVD, and it will change what you do forever. It's like once you've experienced it, yeah, you can't go back, especially when it's things like nerve pain. So I saw a patient last night who had been told that the myofascial pain and the tight, incredibly painful muscles in his forearm were because he used his arm so much as a photographer. And so I was treating his shoulder for having been dislocated. So I had one contact around his neck. And he said, man, if you can fix this pain in my forearm, I'll be forever grateful. So I moved the contact down from just below his shoulder down to his hand so I could treat the muscles in his arm. And there was something about the quality of the pain that reminded me of nerve pain. So I treated the muscle first and nothing happened. And then I looked at where he was pointing at his pain, and it was the C6, C7, and C8 nerve roots. And I thought to myself, well, if it's the nerve, then you switch it to 40 hertz on channel A and 396 hertz on channel B. I didn't tell him what I was doing. So it's really easy to do research with this because the patients can't feel the current. The patients don't know what frequencies you're running. So I switched to 40 hertz on channel A and 396 hertz on channel B and polarized to positive. And in about 5 minutes, his pain started to drop and the muscles started to relax. And in about 20 minutes, the muscles in his forearm were completely soft and completely pain-free. And at 30 minutes, they were normal, and his arm didn't hurt for the first time in 2.5 years. They had offered to operate on his arm and slice open the fascia and grind on the tendons to increase circulation. And can you imagine what a travesty that would have been? Because the problem in his forearm was caused by a disc injury in his neck. When we checked for a small disc in his neck, there it was. So it was nerve pain. Until you have the ability to treat nerve pain simply, easily, quickly, you never look for it. And think about what you miss as a clinician or as a patient. Think about why it is that you're not getting better, or why it is that you or your practitioner can't help your pain or change your situation. Because we can treat nerve pain effectively, efficiently, quickly, without side effects, except that he got kind of stoned. Because we can treat it, it's possible to look for it and to find the areas where nerve irritation and nerve inflammation create the problems that we perceive as either muscle or joint pain. His shoulder was incredibly painful from the dislocation, and we treated all the shoulder tissues, and he was still at like a 4 or a 5. When I treated the nerve, his shoulder pain went away as well. So this new tool changes everything that you're able to do in your practice, and it changes your outcomes more or less forever in a very positive and amazing way. Hard to describe what FSM does beyond that, because on a daily basis, I do things that even I'm not sure are possible. But the frequency response is producible. The frequency response is reproducible, predictable, and in some cases diagnostic. So the frequencies that work tell you something about the patient's condition. So tight muscles in the lower legs are sometimes tight muscles, but sometimes they're caused by inflammation in the spinal cord. And the only way that inflammation in the spinal cord that reduces descending inhibition of tightness or spasticity, the only way we know that is that the only frequency that would take away the tightness in the lower extremity muscles was the frequency to increase descending inhibition in the spinal cord. It changes your life, it changes your outcomes, and the frequency response is predictable enough that it teaches you things about your body and physiology that you would never have thought possible. We are just about winding up. We've got, oh, we're out of time. We've got a few seconds for any more questions. Anybody out there? Okay, well, I encourage you to go to frequencyspecific.com. You can also go to the equipment website, www.precisiondistributing.com, and that company sells bundle packs of both the devices and the course material bundled together at a pretty nice discount. Look forward to seeing you at a seminar, and thanks for tuning in.